There's so much confusing and conflicting information out there around pregnancy and birth, and none of it comes from the people that are actually in the room. We are Sarah and Catherine, two Canadian labor and delivery nurses with over 4,500 births under our belts.
What if the nurse holding your hand during labor could also answer every question you were too nervous to ask your doctor? Welcome back to 4,500 Births Later. We are here with Fiona Mattatall, our obstetrician.
You mentioned your mentor when you're in university and the historical aspect of healthcare.
Mm-hmm.
And I know I've had a conversation with you previously about blood type, Rh factor, and ROGAM.
Yes.
And I'd like you to talk about that and teach us.
Okay. I think this is a medical story that not enough people really appreciate how amazing it is, and that there is a very big Canadian piece to it that we should be so proud of. So with blood types, we have the letters like AB, and O, but then there's this other piece that most of us know. There's like a positive or a negative at the end of that. And the positive or negative is really important in pregnancy, because if someone who's carrying a pregnancy is, and we call it Rh factor, if they're Rh negative and their baby is Rh positive, the body can start an immune response to that fetus. So when we're pregnant, our body kind of gets tricked into ignoring that there's something else growing inside of us, because normally our immune system would reject something foreign that's inside of us. But pregnancy is the one exception. But in this one case, if there is that disconnect in the blood type, then the body will start to recognize that as foreign and try to kill it. And if you were to go back historically, so we're now going back more than 100 years ago, women who were Rh negative, which is about 10% of the population, if they were to get pregnant, marry, have a family with a partner who is Rh positive, which was likely because more of the population is Rh positive, their first pregnancy would probably go okay. Baby might be born, need a little bit of help after. But then every pregnancy after that, if the baby was Rh positive, like the dad, they would lose that pregnancy and they would have stillbirth after stillbirth after stillbirth. And these are the historical stories that I think we forget about. But there are women historically who, this is a time before contraception. They would get pregnant and their baby would die, get pregnant and their baby would die. And these are horrible, heartbreaking stories that these people had to endure. And it wasn't until there was some really good research trying to understand, why does this happen to some people? And part of that research was in Winnipeg, of all places in the world. And that was where there was a blood laboratory at the University of Manitoba, where there was a team working on understanding blood types. And they were part of a research network. There were some in the US as well, where they started to understand, and they had that aha moment that, oh my God, it's a blood type incompatibility. And so the way that we prevent that from happening is with an injection of a compound which kind of tricks the immune system into ignoring that there is a foreign invader inside your body. What is so interesting about what we use as a medication to prevent is that it is a blood product, and it is a collection of antibodies that come out of blood from people who have had exposure and their immune system has responded to that blood type. And what is so interesting is when you look at the research of who has been providing this blood as a preventative treatment for this condition are women who would have had their own antibodies raised because they probably had these pregnancy complications. And so what I think is the research behind it is fascinating, but the humanity in it is that we have a blood product in Canada, which is called Winro. named for Winnipeg. In the U.S.
Didn't know that.
in the U.S. it's called Rogam, and we often use the term Rogam because we're so influenced by the U.S. But if you look at the product that we inject, it's actually called Winrow. And one of my instructors in Halifax was an obstetrician in Winnipeg, and he drilled that into my head. He's like, "Don't let me catch you calling it Rogam. We should call it Winrow and be proud of the Canadian heritage we have in this." This is a gift from women who have lost pregnancies because of Rh isoimmunization, which is the fancy word for when your body raises this immune response, that they gift their blood to other women so that they don't have to suffer the same losses. And I think it just like makes me tear up thinking about what a great gift this is. There was a really interesting article the Globe and Mail put out. This is years ago. Andre Picard, who's a great health writer in Canada, documented the history of this and why this is such an interesting thing. So people can go online and Google Globe and Mail and RH, and you'll find his article that goes through the history. I think it's a lovely story, and it makes you think past okay, we're just testing for Rh disease. We'll just give you the product. And you think about where we have come to in the care of pregnant women. I think about my grandmother, who wouldn't have access to medications to prevent these complications for her patients. And where we are now, that we have the tools to make this, pregnancy a safer and more joyous occasion. Whereas in the past, this one thing would have caused, immense heartache, to people and couples losing pregnancies. And we don't have to do that now. One thing that, was really an interesting reflection when I trained in Halifax. There are 3 main hospitals in Halifax, and we, in our OB-GYN world, had to work in all 3 hospitals. And there was a shortcut between one hospital and another through a graveyard. And I might not have done the shortcut at night if I was like going to see a patient at the other hospital. But during the day, I would, take the shortcut through the graveyard. And usually on my way back, I'd still come through the graveyard. But I'd take a little bit more time and just look at the gravestones. And it hit me one day. I was walking back through and I looked gravestone after gravestone, and there were so many women, and you looked at their date of birth and the day they were buried. They were in their 20s. There were so many women in that graveyard in their 20s, and so many newborn babies in the graveyard. And this is one of Halifax's oldest graveyards. So these were like 1800s gravestones. And it just hit me one day. I was thinking, oh my God, I wonder the skills that I'm learning as an OB-GYN, are those skills that maybe, 100, 150, 200 years ago would have saved that baby or that young woman? Because I imagine many of those young women in that graveyard were there because of pregnancy complications. So it was really poignant to have that little piece of history and a reminder of, yes, this is important work. And this is why we do this. And aren't we lucky as healthcare providers to work in this time where we have all these tools to be able to not have complications that would have been there for our grandmothers or our great grandmothers. But also as a woman having a pregnancy or 2 pregnancies, what I had is to be having a baby at a time where it is so safe compared to what it was historically. But then that flip side is we have so much information, but it's not always good.
Yeah.
And we know, we're able to dig through that information, that's all that information that's out there, and try and understand what's good, what's bad, what is not just bad, but maybe sinister information. But not every pregnant person maybe has the skill set to understand how to look at a medical research or how to look at a social media post and be like, that's just garbage. That's somebody trying to sell something. So
with my first pregnancy, my water broke at the beginning, didn't go into labor, had to be induced, GBS negative, so didn't need antibiotics. But Chloe never dropped into my pelvis. Like she never got below -3.
Little stinker.
Yeah.
Yeah.
And I never got beyond 4 centimeters. And as you know, typically in your first pregnancy, the baby will engage, drop into the pelvis 2 to 3 weeks before you go into labor. And so, of course, I had a C-section. She came out with a beautiful round head. And it really made me feel grateful that I had this baby in 2003, not 100 years previous.
Right.
Because one of us, or maybe both of us, wouldn't be here. We've come a long way.
We have.
Yeah.
And I think if you don't hear the stories or read the stories of what happened in the past for women in pregnancy, pregnancy was not always celebrated. It was almost feared because of the risks associated. And we're at a time now where there is still fear, but the fear isn't that you're not going to survive this process, where it used to be. So I agree. Like, I feel very fortunate that we live in a time where, both of my pregnancies required intervention by skilled providers. And I was very grateful to have those providers care for me, and that I'm healthy and well. And I've got 2 healthy, almost grown kids because of it. So
Thank you for sharing that story. That will stay with me for the remainder of my career.
okay.
And I'll start calling it Winrow.
Okay. Thank you.
My husband's from Winnipeg, so
So there you go.
Yeah.
Oh, yes.
Yeah, very cool story. The history of it all, right? The reason why we do the things
Yeah, it is
we do
amazing.
every day is so important to.
Because of Winrow and the changes that it's made for women, are we going to run out of that blood product to make Winrow?
That's a great question, because sometimes we become a victim of our own success. And my understanding, not as someone who does research in this area at all, I'm interested in the research, but I don't do it, is that there is work to develop a synthetic antibody, because we probably will run out of people who have enough antibodies to prevent this for other people.
Yeah.
So there's work at play in how to make those synthetically.
Okay. Well, that's good. Very good news. And I think our conversation leads us to the next thing we wanted to talk about, which is rebirthing.
Yes.
Hot topic that we're hearing online these days.
And interesting, like, if you think historically, many women free birthed in the past. Before there were midwives, although midwives probably is the second oldest profession, as the joke goes, that women have helped women in childbirth for a long time in history. But there's been times and places historically where women haven't had an educated, trained attendant to help them with childbirth. And there's places in the world where that is true. And we see that in some areas of the world where some of our colleagues actually go to help train people to have a skilled attendant. And what's interesting is now we've seen a movement back that people are choosing to have a pregnancy and a birth without any help from another person, specifically any help from someone who's got training in childbirth. So it is a curious thing. We've heard of cases here locally with some unfortunate, very unfortunate results. There's been a very interesting, deep discussion that's come out of the UK. The Guardian newspaper has done a really good job at taking a deep dive into not just free birthing, but a movement of free birthing, and a podcast. I think we've all listened to it.
Yes.
The Birth Keepers is the name of the podcast. Yeah. And that was put forward by the Guardian as they did a series of articles, but then also a really good podcast taking a dive into this movement and what's behind it. And I think it's where misinformation and fear and monetization of that kind of all meet in the same place, and then throw in a little bit of women's health. And women's health is an area that is ripe for misinformation and people taking advantage of misinformation or maybe lack of knowledge. So free birthing is certainly not something I would ever promote. If I had a friend or family member who was wanting to go a pregnancy without any testing and have a baby unattended, I would work very hard to discourage them from that, because we've talked about all these things that we've, as a community of care providers on the shoulders of generations of scientists and researchers to make women's health safer and to make childbirth safer, to ignore all of that and to go back to a time in history where the chance of the mom or baby not surviving or having significant harm it's unimaginable. And I feel very badly hearing that people may be preyed upon for financial interest in this. And that's what the Birth Keepers podcast did take a dive into, is some of the it's basically a grift of, a few people trying to make money off of this. And I mean, there's no nice way of saying it. There's blood on their hands. And it's a very scary movement. There's another piece of it though that makes me reflect. And is there anything that we can do to maybe counter some of the false narrative that's there? Or maybe we can do better as well, and maybe making better, more trauma-informed spaces for people to come and engage in healthcare. So we own a piece of that, I think, and historically, we can absolutely do better, but it doesn't excuse the misinformation that's out there and causing harm to people.
Yeah, I can think of one episode in particular on the birth keeper, where she was informed by these people, and so she didn't go into hospital until it was quite far down the road. And her response was actually, "I can't believe how pleasant everyone was in the hospital and how accepting."
Yeah.
And that made me really upset to think that the individuals have a feeling of a hospital setting as a terrible place, because I think, especially where we work, it's a very collaborative place. We work well with everyone, and our mission as nurses, as doctors, is to give you the best experience that we possibly can, to listen to your concern, to make this a positive, memorable experience. So it really pained me to hear this woman be almost shocked that a hospital setting was in fact a beautiful place, a safe place to come to.
So, on that note, how do you have a non-judgmental conversation with someone planning a free birth?
Well, I haven't had one yet, although maybe I have and I wasn't aware of it. But as far as I know, all of my patients have come into hospital and had babies. I've had a few who've had home births with midwives as well, but I've not, to my knowledge, anybody have a free birth. I think the first part of it, whenever there's sort of a disconnect with what someone's requests are from a pregnancy or any kind of medical thing, and I'm in a very different place with where I think is the best evidence, that's a big gap to sometimes bridge. So I think first thing is a deep breath, and to take ego out of it, which is sometimes hard for us, especially when this is the focus of so many hours of your life. Training to become an expert in an area, working so much in an area, you can get an inflated ego and like, we know everything. And so first thing is a deep breath and say, okay, let's just take a step back from that and let's connect one-on-one as humans and take away some of that power differential. Cause that can, I think, that is maybe part of the problem as well. And then I think the next place is just trying to ask the why and where is this coming from? Are you maybe getting some not great information, and seeing if there's a way to provide better information to that person? Maybe looking at then getting into some of the details, like what is it about getting tests in pregnancy that worries you? What is it about, being in labor and not with someone who knows how to help you through that and make sure you're safely through that, and trying to maybe dive into a little bit of that why a bit more. The challenge is those are long conversations, and we are not set up always to have those long, detailed conversations with people. And to be honest, if I had a patient who was considering a free birth, I would look at some of the local expertise we have with our midwifery colleagues, because I think they have that conversation much more often than I would, and probably have a better insight into someone who does not want, let's say, an ultrasound to check on the placenta or the baby. And so I think they would be much more skilled in that conversation than I would be. So either asking them for help or seeing if one of them would maybe be willing to have a conversation with that person to see if maybe their approach would be a little bit closer aligned with what they were looking for than maybe an obstetrician. Sometimes we're seen as the big interventionalists. I've been told, yeah, you guys just walk around with a scalpel, just want to do C-sections on everybody. And maybe
that is not true.
Well,
that is not true.
It's not true. But maybe it's because we are the people. We're the only ones who do the C-section.
Yeah.
So that is kind of what we do.
Yeah.
But that is not what we want for everybody. Like for some people, that's the right thing. And, for me, that was the right thing for one of my 2 pregnancies. But that's not right for everybody. But sometimes a midwife might be a less maybe threatening, less interventionalist kind of person to have that conversation with somebody who's thinking about a free birth.
That's fair. Now, along the lines of midwifery and collaboration, and also the collaboration with family doctors that are doing deliveries, what are some reasons why they consult an obstetrician?
So the dynamic between all of us who work in that space is really interesting. So we have nurses. So you are all like the front line of all of this. We have midwives, family physicians who do low risk pregnancy care, us obstetricians. We also have anesthesia physicians in our space. And that mix can be different depending on where you are in Canada. And I didn't really appreciate that until I came out into practice and was comparing notes with, my friends and colleagues around the country. So it might be quite different in Calgary compared to Victoria, BC, compared to Halifax. And so the mix is a little different, and the why they might consult might be a little bit different. At our site and in Calgary, we have very skilled midwifery colleagues and very skilled family physician colleagues. And we all come to this space with overlapping skills, but like the Venn diagram of our skills aren't a complete circle. We all have some extra things that we are all a little bit better at. So like I mentioned, with midwives might be better at having that conversation with someone who is looking for a home birth or a free birth or a water birth. I come to the set with skills of knowing how to use forceps or a cesarean section. A family physician has the most breadth of knowledge because they know all about all parts of the human body. And then these are skilled colleagues who have then taken a little bit more focus on women's health and pregnancy care. But they still, like, if someone comes in with sinusitis or I had shingles on call. It showed up once when I was in a meeting with one of our family physician colleagues. Really helpful that she knew what shingles was. I'm not an expert in skin conditions at all, so I had no idea what was going on. So we all have these really interesting overlapping skill sets. So, when does a family physician or a midwife consult an obstetrician for help? I think universally would be for something like a cesarean section. Usually for forceps, there's not that many family physicians in Canada who've used forceps. Some are skilled at using a vacuum in labor and some are not, do not use vacuums. From what I've seen, most midwives don't do any of the above. So if there's a need for that intervention in labor, that would be a reason to bring an obstetrician in. Then there are sort of less acute, less procedural things. And that is if someone is having a pregnancy that falls out of that sort of typical low risk. And that is not most pregnancies. Most pregnancies are, healthy mom, healthy baby, no other concerning things. But sometimes these interesting things show up, or maybe it's in someone's history. So let's say if someone's having twins or triplets, that's not usually something that a midwife or a family physician has trained to be part of looking after that pregnancy or for the birth of the babies. If the pregnant patient has a medical background, that could be complicated. So let's say they've had a transplanted organ before, or they've got another health concern. That might be a reason to involve someone who has done training in how to look after someone who's pregnant who also has this other medical thing. And then sometimes there's things that happen in the pregnancy or in labor, like worry for an infection, like we talked about with, long ruptured membranes, or if it looks like the labor's not going well, the fetus isn't tolerating labor, that might be asking an obstetrician for a second opinion on how to anything we need to do differently, or trying to expedite the baby coming into the world for the health of the mom and the baby. So there's lots of different reasons, and depending on where they are, we might be a little more involved in that, might be a little less involved, depending on the geography, and sometimes depending on what the capacity is from a staffing perspective. In some places have a lot of obstetricians and not a lot of midwives or family physicians. Some places might be the opposite, maybe a lot of low-risk providers and very few obstetricians. So the obstetricians might not even be in the building 24 hours a day, whereas in our 4 hospitals in Calgary, there's an obstetrician in-house and on site at all times. And then the roles that you play as nurses is like the glue between all of that. And you all have a hugely important job doing that one-on-one with patients, where we may be in a couple of rooms at different times, at being that first set of eyes, communicating that information to us if there's concerns, and also navigating what can be a tricky dynamic of sometimes different other people, like maybe a midwife and an obstetrician, both being involved in care of one person. And that can be an interesting navigation. Every labor unit has different ways that they navigate that.
Mm-hmm.
And we've developed our own at Rocky View. And I think it has worked very well over the years, and there's always room for improvement. But I think we've come a long way from when I started, and we had very few midwives around. I think we're doing a much better job.
I had an interesting conversation with a midwife the other day, and she was explaining that a big part of her job in the clinic and in hospital is to speak to her patients about the chance of having an OB consult at some point and getting their feedback at that time. There is a respect between midwifery and obstetricians. And as you had just explained, different skill sets. It was her job as the midwife, she felt, to make that a really positive experience, because some patients that are under midwifery have the trauma with the medical system. I thought that was really cool that she acknowledged that and made an effort.
That is so good to hear and so appreciated. I think, as we were talking earlier about social media and how, conflict and emotive things are what get attention. And I think the narrative of that there is conflict between a midwife and an obstetrician gets perpetuated, and it's not the case. And to have that seed planted early, like during pregnancy care, that we're a team, and to counter the narrative that's out there that an obstetrician is to be feared and we're just there because we want to do C-sections on everybody, which is not the case, is really helpful, so that I think that the client of that midwife will come into the process with less fear, thinking, oh my God, what if I have to meet an obstetrician? Because we sometimes get labeled as this like scary, faceless doctor. And I'm biased because I'm one of them, but I don't think we're as bad as we are sometimes portrayed out there in what's in like that most of the public would have access to, whether it's social media or, print media. And to sort of lay down that during the pregnancy is so helpful, so that if an obstetrician does need to meet this person in labor, they're not going to be scared, that it's just it's just normalized. the other thing I really appreciate with our midwifery colleagues is, and I've noticed this over the years, has gotten so much better, is if they're just worried about something, and it's not necessarily like we need to intervene or anything, but like, can I just get a second set of eyes on this? Like, can you just come meet this patient, see what's going on? And it allows me to come into that space in not a stressful moment and just say, hey, this is who I am. Learn a little bit about them. If there is something like a medical history or a trauma history, I have a better chance of understanding that in a non-stressful scenario. And if something does start to go sideways and we do get into a stressful place where we're really worried about the mom or the baby, then I'm better prepared to look after that person much in a much better way if I know a bit more about them. And that can be really helpful to have that grounding before. And sometimes a midwife will just say, oh, patients had a sexual assault in the past, or they had a negative healthcare experience as a child. And if they know that, communicate it to me so that will definitely change like the language I'll use, how I'll approach the patient. Again, we try to approach everybody in a trauma-informed way. But I think that leads that patient to maybe a less traumatic experience, even if it does end up in something like an emergency cesarean section, that we've had a bit of time to lay a bit of groundwork, develop a bit of trust, rather than, at the 9th hour coming in saying, oh my God, you're in trouble. We need to get your baby out right now, and have had no background relationship with the patient. So it can be tough, as we all know, making those connections with people quickly in a stressful time is hard. And our midwives have been very good at giving us the gift of a little bit of time in having us maybe involved a little earlier to allow for that. And I think the work that's been done on our unit with nurses working with midwives and having a bit of an opportunity to get to know these people having babies with us before, and hopefully not having any stressful situations, but it's really nice to have that relationship before if you can.
Absolutely. Thank you. So along the lines of midwifery,
Okay.
The consult process and what that looks like, I think you've just described it basically. And also I think you have described it as being collaborative, not hierarchical. In the end, somebody needs to make the decision, right? So it's good to have some leadership that way.
Yeah.
And of course, informed consent.
And that's one thing that we've been working on as a team of obstetricians and on our unit is it's interesting when you have two people caring for a patient on the same level, like a midwife and an obstetrician. We have run into some challenges in some situations. And I learned this when I was doing, I had a role in leadership and reviewing cases that went well and cases that went badly, or could have been done better. And one thing I noticed is when you have a patient and there's a team looking after them, sometimes a decision needs to be made or a call needs to be made. And if it's not clear who is that person, it can be confusing. And I've reviewed cases where we had two people, a low risk provider and a high risk provider, both thinking they were that most responsible person. And that led to conflict and confusion as to, okay, well, who's making the final decision here? I mean, ultimately, ideally, the patient is in a position to be able to make a final decision, but sometimes that does not happen. I've also reviewed a case where the low risk provider and the high risk provider both thought the other was the most responsible person. And so rather having overlapping conflict, we had two people sort of saying, not it. And then we had a less than ideal outcome because there was a time lag in trying to understand who's finally responsible for this. So we've come forward as a team in Calgary, but our team at Rocky View, looking at the concept of what we call MRP, most responsible person. And it's inherently safer if the whole team, including the patient, know at any one time who is the most responsible person for your care. Like if it's, sorry to use, I won't use bad language, but if it's hitting the fan,
Yeah.
who gets the phone call and who, who is ultimately, and from a legal sense as well, who is ultimately responsible. And so we've been trying to work on being very clear and not having that, like, we don't know who is most responsible, and to have it clearly documented and communicated to everybody that, okay, if the heart rate goes badly for the fetus, who do the nurses call? Do they call the low risk provider? Do they call the high risk provider? Because in times like that, sometimes minutes and seconds are really important, and taking time to sort out some confusion as to who's ultimately needs to be called that's unnecessary work. So that's one thing I've been really a little bit A-type about is, and when I'm working with learners and that, just to say, okay, who is ultimately the most responsible person at this point. And there's not always agreement. I've had situations where a patient has said, I do not want you involved in my care. And I'll have a conversation with their low risk provider and say, okay, the patient has said that they don't want me there. So you can't invite yourself to these parties. And so that you are the most responsible person. Call me if you need me. And if there's a change of mind, I'm there. And I've also had situations where the low risk provider has said, no, I would like to remain in this role. And I can say, well, here's the reasons I don't think that's a good idea. But ultimately, if you and the patient feel that that is most appropriate, that's your call. Again, you try and let ego step out of it and say, I'm here if you need me, but I'll take myself away from the situation. But usually it goes very collaboratively and cordially. And I'd say most often our lowest providers, especially if things are getting a little bit complicated and stressful, are often very happy to say, come to the party,
Take the wheel.
and it's not like they leave the party. They stay involved in the care of the patient and the newborn when they arrive.
I think that's a big mark to stress, because I think a lot of people feel that once the obstetrician becomes involved, the midwife is no longer involved.
Yeah, that's not the case at all.
And it's not.
Yeah.
They are still in the room.
Mhm.
They still provide care, as you said, to the baby. So
Yeah.
I think that's a really big point to stress, is they're still very much involved in your care. They don't vanish and you never see them again. So
Exactly.
we had Alex on here the other day who had a C-section and with her fourth baby. And she was surprised at that. She said, if I booked a C-section, I thought my midwives, I wouldn't see them again.
Yeah. Yeah, I
So
saw that podcast. That was really good.
very, yeah.
It's not either or.
Mhm.
It's like when someone gets married, you don't lose a daughter, you gain a son-in-law, right?
True.
That's right.
But it is really important for everybody to know who the most responsible provider is. Yeah. That's
It's
a big one.
important for communication.
Yeah.
And that's true in other areas of healthcare as well. Like in the operating room, where I spend part of my other time in gynecology, is, if something's going not well, you have a surgeon and an anesthesiologist, and it's a discussion between us. Okay, what are you taking? What am I leading? And so that conversation happens in other areas of healthcare as well. But in the labor room, it is a particularly emotional and stressful place compared to some other areas in healthcare. So it's messy, but it's wonderful.
It keeps us coming back every
That's
day,
true.
doesn't it?
Yeah, it does. It does.
Indeed. We'll see where you go with this one. We've touched a lot on different things, but basically, what makes a good working relationship with a medical doctor and midwife, and what makes a difficult one?
I think what makes a good relationship is communication and trust, and that goes both ways. We can have a healthcare provider, physician, who doesn't come, bringing trust or communicating well. But from the patient's perspective, Being honest can be really helpful. Being open about worries and fears is really helpful. Those can be hard conversations, and there's a time and place for those conversations. And our job is to make spaces for those conversations to happen. I find lists really helpful when people come to a visit, when a patient comes to a visit with a list of questions, a list of priorities, a list of medications that they're on. And I found this as a patient as well. Sometimes, you're sitting waiting to see somebody and you start thinking about everything else and you're like, oh, damn, what was I going to ask my family doctor? So having them written down, I think, can be a really helpful tool for visits in the office and for, getting through, either a very straightforward prenatal visit or getting through a very complex conversation about something in pregnancy that's not going well. So I think those are the keys.
Okay. Thank you. And from your perspective, what did midwives bring to birth that complements OB care?
I think we've touched on some of it. Like, I think what I've seen with our team is opening our eyes a bit more to trauma-informed care has been really helpful. Midwives, the way that our healthcare system has set up models of care, midwives have the gift of way more time with each individual client or patient than our setup is as physicians. We're expected to see far larger numbers of people in pregnancy. And like we talked about as well, like sometimes meeting them on short notice and making some pretty quick decisions, whereas midwives do have that longer time to spend with people, maybe take deeper dives into hopes and wishes and background. So, bringing forward one of their clients into our labor space, they know so much about that person and what's important to them. So that is a huge gift. I think they bring forward skill sets that we don't have. The thought of a baby being born underwater is honestly something that is really scary to me because that's not something I've trained with or have any experience with. So, a different skill set, whereas the operating room doesn't scare me, but that would scare maybe most other people. So I think those are the main things that are really helpful. And honestly, the team of midwives who we have been working with at Rocky View, they are the most interesting women and come with really different perspective. And it's been a really nice addition. One in particular who also teaches midwifery at our local college. I have learned a lot from her as well.
That's awesome. Okay. So I think we've discussed a lot. I've got my last question for you, but is there anything that you would like to share?
I guess the other thing we have added at Rocky View, and I've heard of other places that are doing similar, is we've added another healthcare worker in our space. Yes. And oh my God, we are so lucky. So we realized as a team of obstetricians, actually, we realized for a long time, but about 2 years ago, we applied for funding for an expert helper. And so we interviewed a number of physician assistants and nurse practitioners and hired a physician assistant who helps us with our daily work on the unit. And a physician assistant and the physician assistant who we are very lucky to have also teaches at the program at University of Calgary, which trains physicians. So aren't we lucky? We've got all of these people who do this work, but are also training the next generation to do this work. So she has a defined skill set and a role on the unit. So as someone who is not a physician, she is not able to perform surgery, but she can assist in surgery. She is very helpful at doing assessments in our little triage, which is our little emergency room. And we have worked with her to be very good at, the top 30 things that would bring somebody who's pregnant into that unit and how to start that, know all the right questions to ask, know all the right tests to do, interpreting those tests. She's also been starting inductions of labor for us, which has been really helpful because sometimes as the OB sometimes I have lots of time and I can go hang out in triage with all of you wonderful folks and see most of the patients who are there. But sometimes I'm pulled over to the labor floor because there's more acute things going on, like needing to be there for the birth of a baby or a cesarean section or, looking for after a postpartum hemorrhage, all of those things that is sort of our bread and butter, but then that leaves some other work undone. So we've been very lucky to have a physician assistant help us with the busy work that we have on our unit. And so we're very lucky. And I think she's integrated so well on our unit and has made it the lineup of getting care and triage is a lot better than it would be if she wasn't there. It would look like our regular emergency rooms, I think. Just people in the hallway if we didn't have her skill set there. And then I guess the other piece that we also have are learners on our unit. And I think sometimes that comes as a surprise to people. But every hospital in Calgary is a teaching facility and we teach learners of different types. We have residents who are physicians who've graduated medical school and then are going into other areas of medicine. So we might have residents with us who are going to be obstetricians like me, but we might have residents who are going to be a family physician or an anesthesia doctor. So these are all people who work in our space, who will be working in our space as independent practitioners. I feel really important that we have those spaces to train the future physicians because I wouldn't be able to do my job if I wasn't in a healthy teaching environment where I could learn. Now they're not unsupervised, and definitely the more senior they become, the more we step back as staff and let them make a few more decisions. But when they're like first out of medical school, we're, on top of everything. So they're not unsupervised. But we also have nursing students routinely through. We have paramedic students show up on our unit. Any other learners?
Medical students too.
Medical students as well. Yeah.
Midwifery students.
Midwifery students as well. Yeah. And sometimes I think patients don't want learners. I think that's maybe coming out of a fear of, oh my God, like is somebody who doesn't know what they're doing first day out of nursing school or medical school going to be looking after me? And that's not at all what happens. And it's interesting. There's actually very good data, both Canadian and in other places in the world, that shows if you are being cared for any medical condition at a teaching facility, your outcome is going to be better than if it's at a non-teaching facility.
I believe that. Yeah.
And I've certainly seen that myself, that, as we do our work, our cognitive bias gets very narrow, and I will always go to uterus and ovaries being the problem because I'm a gynecologist. And it sometimes takes a medical student to say, could that be a bladder infection? And it really helps. I'm a better doctor when I have learners around, and it raises my level and corrects that cognitive bias that I have from being in practice for so long. So I think they are an unrecognized, very poorly paid part of our team that we sometimes forget about, and I think often have a negative connotation, but absolutely not. And not to mention that I really enjoy teaching, but I really feel like if we make our spaces really good for patients and really good for ourselves, we will attract the best of the best into reproductive and sexual health, which is, I feel my goal is, and I'm always telling med students, like, this is such a great job, such a great career. You get to work in these teams. And I want the best of the best to do this work because I think it's so important.
I agree. I really agree. When you're talking a few times about time, not necessarily having that full amount of time with a patient at the bedside and the different areas in which you're pulled, I have such a visual of you and beep, 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 beep. Like there's just always these interruptions, no matter what you're doing. You could be scrubbed in doing a surgery and the pager's going off. And, as nurses, we do our best to kind of know where you are. So we're trying not to disturb, but inevitably we need to get a hold of you.
Yeah. And sometimes learners are really helpful because they have more time because they're not being pulled in as many directions often. And so whether it's a nursing student who goes in to take that first history while you are balancing a couple of different patients in triage, they might get more information because they've just got that extra time with somebody. So that is inherently makes that a safer journey for that patient. And maybe she gets to disclose that piece of trauma that we wouldn't have gotten to, which will then alert it to the team, and then we will all be aware of that as she goes through that journey.
If you have any questions about what you heard today, please reach out. Sarah and I would love to hear from you. Email us at birthslater@yahoo.com. That's birthslater@yahoo.com. We are here to support you every step of the way. And now for the legal language. This podcast is solely for educational and entertainment purposes. This podcast is not intended as a substitute for professional advice from qualified individuals involved in your prenatal, labor, and postnatal care. Every pregnancy and birth is different, so always talk to your healthcare provider about what's right for you.